Good morning, everyone, and thank you for joining us. This is a webinar put on by the American Heart Association on strategies to increase RSV vaccination rates. My name's Joseph Miller, and I am a clinical associate professor of emergency medicine and internal medicine at Henry Ford Health. And I am joined by a great panel of clinicians that it's our pleasure to talk to you about increasing RSV vaccination rates. And as we go, each clinician will introduce themselves in turn. As a brief disclaimer, the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. Materials are for educational purposes only, do not constitute endorsement or instruction by AHA or American Heart Association. The AHA, ASA does not endorse any product or device. So I encourage everyone to please be interactive during this webinar, and please open the Q&A feature at the bottom of your screen and drop questions throughout the presentation. And we'll answer these towards the end of the presentation as time permits, and really welcome your questions and discussion points. These are our faculty and their disclosures. And here are our learning objectives. So first, at the end of the presentation, we hope you can discuss new RSV vaccination recommendations for adults aged 50 and older, that you can describe the clinical considerations for timing of RSV vaccination for the current season and for co-administration of these vaccines with other vaccines. We hope you can evaluate current RSV vaccination rates in adults, review vaccine hesitancy, and discuss strategies to appropriately recommend RSV vaccines to adults. With that, I'm going to turn the presentation over to Allie Staten, who will give her own introduction. Thanks, Allie.
Hello, everyone. It is a pleasure to be with you today. My name is Allie Staten, and I am a pharmacist in Arkansas. I work with our immunization coalition in Arkansas, and I'm also a pharmacy owner. So I do work in an independent retail pharmacy. So today I'm going to be discussing the recommendations for RSV vaccines, and they have recently changed. I don't feel like I've seen a lot of news around these recommendation changes recently. However, it did happen a few months ago with ACIP's discussion, and then it was recently signed into ACIP and CDC official recommendations. So one thing that has not changed is all adults ages 75 years and older, one dose of the RSV vaccine is recommended. This dose is a one and done dose for RSV vaccines. So it is not recommended for any patient to receive more than one dose of an RSV vaccine. It is once in their lifetime as of right now. That may change in the future, but as of right now, it's only one-time dose. Now, what has changed recently is for adults that little bit of a younger age group, for the ages 50 to 74 years, those patients are also recommended to receive one dose of an RSV vaccine, but this is based on risk factors. Recently, or before this change, it was ages 60 to 74, and now it's been updated to be 50 through 74. And this is based on risk factors for severe RSV disease. And those include chronic medical conditions like chronic heart disease, chronic lung disease, diabetes with complications, immunocompromise, other risk factors, long-term care facility residents. And these definitions are available on the CDC website for these risk factors for these patients. But really wanted to point out that the recommendation has changed to ages 50 through 74 for those patients who are at risk for severe RSV disease. Let's see. There we go. Okay, so this is a chart that we've created at Immunize Arkansas to really help point out the differences between what is FDA approved and what is CDC approved, because there is a difference. And what that means is really with FDA approval, that's what goes into the package insert. And with CDC approval, that's what's approved and recommended by CDC, ACIP, and those recommendations are generally what insurance covers. So that's an important consideration whenever you're recommending vaccines. We really want to try to go off of CDC, ACIP recommendations, but these vaccines have been approved or recommended for maybe different or maybe approved for different populations based on FDA. So, what I really wanted to point out on this slide is that FDA approval and ACIP approval is different for each vaccine. So, there are three different vaccines for adults, and you can see them here. What's kind of what. And one of them is an adjuvanted suspension, one of them is an mRNA vaccine, and one of them we just call it RSV pre F. So, with these, the one that is just the RSV vaccine, we call it RSV pre F. That one is approved in pregnancy as well. Now, notice that the other two are not approved in pregnancy, but there is one that is approved in pregnancy. So for this, again, I just want to point out that the risk-based recommendation has changed. It's now ages 50 through 74. All right, so preventative strategies and timing. This RSV net here really shows the timing of RSV seasonality from the past. And we can see that peak season is typically August to October in most of the continental United States. Um, for eligible adults who have not previously received an RSV vaccine, they may be vaccinated at any time of the year. There is no there's no there's no official there's no official recommendation that says that they cannot be vaccinated during certain times of the year or that there's a specific time frame where they have to be vaccinated. So for this older adult age group, they can be vaccinated any time of the year. However, it is recommended to try to vaccinate during late summer or early fall before the peak RSV season for optimal benefit. But again, that does not prevent somebody from being able to get a vaccine in the middle of the summer if they'd like to. But we prefer to do late summer, early fall for optimal benefit. Again, generally, RSV season is August to October in the continental United States. Right now, we know that immunity lasts for up to 2 years, and the current recommendation is for a one-time dose. That's based on the current evidence, currently what we know, and that may change in the future. So just be aware, keep your eyes and ears open for if there are recommendations for another dose for patients in the future. Okay, so at this time, I would like to introduce Dr. Miller to go over co-administration, clinical considerations, patient counseling, and vaccination rates.
Thanks, Allie. In terms of co-administration, the RSV can be co-administered with other adult vaccines during the same visit. Most commonly, consideration of co-administering RSV with influenza and or COVID vaccines together is reasonable and approved. Now, limited data suggests that co-administering this vaccine with others may result in lower antibody titers. But the clinical significance of these lower titers is currently unknown and something that is still being evaluated as these newer RSV vaccines continue to be used in routine clinical care. So now, of note, as you're advising patients and having shared decision-making with them, co-administration of an RSV vaccine with one or more vaccines, such as influenza, may increase the common side effects such as pain, muscle aches at the site of injection, etc. Nonetheless, given our busy lives and ability to get into clinics or pharmacies for getting vaccine, simultaneously administration is likely the best option for most patients. So when deciding whether to co-administer other vaccines with an RSV vaccine, consider: one, is the patient recommended other vaccines based on their age, risk factors, etc.? And often in case, for example, with influenza, the answer would be yes. Second, how feasible is it for the patient to return for a second vaccine visit based on their ability for transportation or other considerations? What is the risk for acquiring vaccine preventable disease? What are the vaccine reactogenicity profiles? And acknowledging patient preferences. So when we're considering and counseling patients for the RSV vaccination, there's 3 RSV vaccines available that Ali mentioned. So 2 of these vaccines are protein antigens, RSV pre-F3 and adjuvant, and both of these were approved in 2023. And then one vaccine is an mRNA encoding that's encodes for stabilized pre-fusion F glycoprotein. And this one was approved in December 2024. We know from data that has come out since the approvals in 2023 that the protein antigen vaccines save lives. So for every, so if we as providers and public health clinicians administer 1,600 to 1,855 RSV vaccines, will likely prevent 1 RSV-related death. And for hospitalization, if we administer 233 to 261 RSV vaccines, will likely prevent 1 hospitalization in the high-risk group of adults over age 75. Data on the mRNA vaccine we're still waiting for that data, particularly because it's just approved a year and a half ago. And then the chart on the right shows that there is some differences between the vaccines in terms of the effectiveness to reduce ER visits and hospitalizations between the two. So a little more data on the RSV vaccination rates. So if we look since 2023 when these are approved, and particularly look at data over 2024 to 2025 among adults aged 75 and older, we see that the overall uptake of those reporting that they ever received an RSV vaccine was around 47.5%. And then an additional 8% reported that they would definitely get the vaccine at some point. And then the CDC has a great dashboard that tracks this kind of data. The links are included at the bottom. And here on the figure, you can see that among those with chronic conditions, age 75 and older, which are demonstrated by the dark blue line and dots, the uptake is a little higher. And among those that do not have chronic conditions, which is the green line, they have a lower rates. Together, though, again, around 47.5% of patients have received the RSV vaccine. Now, if we look at adults aged 60 to 74, and this data was compiled before the change to 50 to 74 with high risk conditions. But if we look at this group with high risk conditions, the vaccination rate is a little lower at 38.1%, and an additional 10% of patients who responded stated that they would be willing to definitely get the vaccine. And all these rates of vaccination vary by disability status, health insurance, poverty, race, and ethnicity. But in general, those with comorbidities are having 38.1% uptake among this age group of 60 to 74. Okay, with that, I'm going to turn over the slides to Amy Braddock, who will introduce herself and talk to you more about vaccine hesitancy.
Thank you, Joe. Hi, I'm Amy Braddock. I'm a family medicine physician at the University of Missouri in Columbia. I care for adults and children both on the inpatient and outpatient service, as well as supervise medical students and residents. So I have a lot of firsthand experience about both the challenges and benefits of encouraging vaccines with our patients. And when it comes to vaccine hesitancy, it can be easy to get frustrated with these patients. It feels like they're making our jobs harder. But I find that it can be helpful when there's conflict like this to really take a step back and try to focus on common goals. Vaccine hesitant patients, they're not the enemy. They just have different questions or different beliefs about what's in their best interest. They may have different exposures or influences than we do. So I think focusing on the common goal of our patients' health and safety can be really helpful. We know that vaccine hesitancy is a major problem worldwide, but we also know that vaccines do an amazing job of preventing premature deaths. The World Health Organization estimates that vaccines since 1974 have prevented about 154 million premature deaths, which is pretty amazing if you think about it. It prevents an estimated 3.5 to 5 million deaths a year. And so this is really, to me, one of the most important things that we do as healthcare providers, as pharmacists, is encouraging these vaccinations. But we know that there's room for improvement. An additional 1.5 million deaths could be avoided globally if vaccine rates were increased. And the World Health Organization has really identified this as a major global health challenge. In 2019, the WHO named vaccine hesitancy in the top 10 threats to global health. And we know locally that geographic clustering of epidemics happen as vaccine rates go down. So you're probably familiar with the increased rates of measles we've been experiencing lately. In 2000, the U.S. had functionally eliminated measles, but cases have begun to rise again in densely populated neighborhoods and communities that refuse the MMR vaccine. In 2022, New York City experienced a varicella outbreak for that very reason. I think it can also be helpful to keep in mind that vaccine hesitancy has really been around since vaccines themselves. This is a cartoon from 1894, an anti-vaccine publication in England. So really, vaccine hesitancy has been around since at least Victorian times. And when it comes to the reasons that a lot of patients report for vaccine hesitancy, they usually fall in these kind of four broad categories. And while a lot of the vaccine hesitancy literature comes from pediatric literature, a lot of these same reasons apply to adults as well. So we're going to go over all four of these. The first broad category is patients that question the need for vaccines. Many patients or parents haven't witnessed the severity of vaccine-preventable disease. And really, this is due to the widespread effectiveness of these vaccines. It's just not top of mind because the vaccines have done such a good job of reducing the disease burden of these infections. And some parents or patients may believe that they or their child, if they were to contract the vaccine-preventable disease, it'd be easy to treat and not have long-lasting consequences, which we know to be false. They also may believe that natural immunity is superior to immunity achieved through the vaccines. Or they may believe that the rate of vaccine-preventable diseases is low, so they're not going to obtain the disease. And that's may be actually true, but that's true once again because these vaccines are so effective. And as I mentioned, as the vaccine rates decrease, the rates of these diseases, especially in these kind of clustered areas, start to rise. We know that a highly immunized population is really important for that herd immunity, which really protects all of us. The other next broad category is the patients may question vaccine safety. The concerns about safety or the long-term side effects of vaccines may be an issue for some patients. Most of the time, this occurs because they will highlight a rare incident in which a patient suffered from an unforeseen side effect of a vaccine. There may be concerns about a live virus vaccine, such as the MMR or varicella. This doesn't apply specifically to the RSV. But they also may have concerns about safety of newer categories of vaccines, such as the mRNA vaccines, which might apply to the RSV. And then, as was mentioned earlier, they may have concerns about simultaneously administering multiple vaccines, that it may overload their immune system. It may reduce some of the effectiveness, but once again, we have to weigh that against, the ease of receiving multiple vaccines at the same time. Sometimes this results in delayed vaccinators in patients that don't want to receive multiple vaccines at the same time. I think, to me, the best way to combat these concerns are just to be honest and transparent with our patients. We know that these vaccines do have potential side effects, so I think it's important to discuss those with our patients. But we also need to compare the risks of the vaccines to the risk of not vaccinating, which greatly outweighs the risk of the vaccines themselves. This next one I think is a little bit more tricky, and that is religious objections. Some religions or patients may have objections to components of the vaccines that violate their religious tenets. And the most common ones of these are animal-derived gelatin, which once again doesn't apply specifically to the RSV vaccines currently available. But another concern that some patients may have is that it may contain fetal cell lines. We do know that some of the vaccines are fetal cell lines are used in the production, such as rubella, varicella, Hep A, and rabies vaccines. But the final vaccine products do not contain human fetal cells, so you can reassure your patients of that. And while this doesn't specifically apply to the RSV vaccines currently available, the current RSV vaccines do not use human fetal cell lines either in their development or the production. They are typically made using recombinant protein or mRNA platforms and developed in cell lines such as the Chinese hamster ovary or CHO cells. And while this is not human fetal cells, they may have objections to these animal cell lines. So it's important to be aware of that. I find it helpful with these patients to encourage them to speak to their local religious leaders. That can really help them clarify which vaccines are acceptable and which ones are not. And we know that only 4 states don't offer religious exemption for vaccine mandates at school. And we've also experienced as these religious exemptions become looser and broader, that vaccine rates for children significantly decrease. And the last category is just request for more additional information. This is not true vaccine hesitancy. Patients are just seeking more information. So I think it's important for us as healthcare providers to not misinterpret questions as true resistance. Most patients actually report that their healthcare providers are not easy to talk to about vaccines. So there's definitely room for improvement on our part there. Patients want detailed information of benefits and side effects of vaccines, which can be challenging to provide in a busy clinic. So I rely on handouts a lot for that. But most parents still trust providers. Most patients still trust providers as a knowledgeable source of information. 81.7% of parents say that healthcare providers are one of the most important sources of information about vaccines. I'm just going to briefly go over some of the differences of social media disinformation versus misinformation. So misinformation being inaccurate information without the deceitful intent, whereas disinformation is inaccurate information with malintent, and malinformation, accurate information, but it's shared out of contact with the intent to harm. So we've all experienced with COVID-19 how the social media epicenter of misinformation really undermined the trust in reliable information and really damaged perceived credibility of healthcare providers, as well as magnifying that polarization. So getting specifically to the RSV vaccine, this was from a study last year in 2024 of 4,082 adults in the U.S., and they reported their reasons for not getting the RSV vaccine. And you can see the most common was just lack of knowledge about RSV and RSV vaccines, both among patients as well as healthcare providers. They reported that their lack of knowledge of the frequency and severity of the RSV vaccine and risk factors was about 22%. Some patients just hadn't talked to their doctors about it yet at 28%, or my doctor didn't recommend it, which is really kind of surprising at 26%. And then 18% reported concerns about the safety of RSV, with a heightened concern due to GBS as well as lack of trust of new vaccines, or once again, that multiple vaccine burden. And I think it can be helpful with patients that we perceive as vaccine hesitant to really know that they're kind of along a spectrum. And really, some may fall in kind of fall into the delay or refuse or accept but unsure. And we really have few in that kind of very red refuse all. In those patients, I find it helpful to just plant the seeds and sort of move on and visit again in future visits. So now I'm going to turn it over to Dr. Solomon, who's going to talk about strategies to increase RSV vaccination rates.
Thank you, Amy. Thank you, everyone, for having me. My name is Jihan Suleiman, and I'm the Medical Director of Infection Prevention and Control and Antimicrobial Stewardship at Henry Ford Health, and an infectious disease provider. We will talk about some strategies to increase RSV vaccine uptake. And we know that these strategies are applicable to all vaccines. Generally, a physician recommendation has a large influence on the vaccine uptake. As Amy mentioned, what we say and how we interact with the patient really influences vaccine uptake for our patients or the patient's caretaker. Generally, the presumptive approach where the provider offers vaccination and followed by a strong persistent recommendation if there's some hesitancy can strongly increase vaccine uptake. For example, during a visit, you say that your child needs these 3 vaccinations. That's the presumptive approach. However, that may not always work for everybody, especially those who have some concerns about the vaccine or are not ready during that visit. Then we will go to the motivational interviewing or the patient-centered collaborative approach to increase vaccine uptake. This approach should be used to address both concerns and benefits, as well as reinforcing the patient's motivation to increase vaccine uptake. And with this approach, you're going to respect the patient's autonomy and individual decision-making. During the session, you're going to elicit the concerns, try to figure out what the hesitancy or why there's a concern about the vaccine before you offer any education. Obviously, how you approach it will depend on what the concerns of the individual are. Through this, by listening and being transparent, you're going to build trust and potentially increase vaccine uptake. And as Amy mentioned, vaccine readiness is a spectrum, and we generally want to target those who accept or refuse some vaccines, not those who are outright refusing the vaccines. Next slide. First and foremost, it's going to be very important to listen to the patient, to, like I said, elicit those concerns. Try to gauge what they have heard and what they know about the vaccine, and doing so without interrupting the patient. Let them get all their concerns across. And then before you move on, validate their concerns and questions. Next slide. And obviously, we do want to educate, but we don't want to provide too much information that will be overwhelming to the patient. During the first session, it may just be listening, and then providing some facts, and then letting them think about it, and then potentially have them come back to discuss further. So during this educational session, you want to provide some key facts about RSV and which individuals are at risk, and then educate on how the vaccine works and its safety profile. Being transparent is going to be important. And it's also important to use plain language that the individual will be able to understand. And if you have any personal or clinical experience that's relevant, it's going to be important to share that so the patient can relate to what you are discussing. Next. And depending on what the questions or concerns are, you're going to offer them tailored material. If they still have some questions, the CDC does have some great handouts. Sometimes it may be via a QR code link or paper if an individual doesn't have a smartphone. And then also the custom clinic summary sheets can provide information. And as I mentioned, you can schedule a follow-up visit to discuss further if there's still concerns or hesitancy about the vaccine. Next. Okay. Additionally, we do want to respect the patient or the caretaker's timeline. I know we want to get everybody vaccinated, but if they are not ready, they will not be willing to accept the vaccine. We don't want to push. And then some things you can suggest are you'll send in the prescription so they can fill it when they're ready, or talk to the pharmacist. This would be for medications, for example. And also you want to keep the door open, not close it. Sometimes providers may discharge a patient from the clinic, and that is not the goal. And then also it's going to be important to reinforce their right to choose and their autonomy. I think that will be, it'll make them more willing to accept the vaccines. Next. Additional strategies to consider: employing people to help you, using a team approach, including pharmacists, nurses, medical assistants, who will help remind the patient about the vaccines. And this can potentially increase the acceptance rate significantly. You can also set flags or alerts in the EHR to revisit the vaccine discussion when the patient comes back. And then we've already mentioned the right to choose. Next. We will move forward to a panel discussion. We have four cases that we will discuss moving forward. Okay, the first case is a 65-year-old who has questions about getting an RSV vaccine and has risk factors, including a myocardial infarction 5 years ago that was complicated by heart failure with a reduced ejection fraction of 40%. In addition, the patient has type 2 diabetes mellitus with peripheral neuropathy, who is on an oral antihyperglycemic agent. I'm going to open it up for discussion and ask our panelists what their approach is for discussing RSV vaccination recommendations for this patient. I don't want to pick, but Amy, do you want to start?
Yeah, sure. I'll jump in there. So based on their risk factors and age, they would definitely qualify to receive the RSV vaccine. I think, just having kind of a patient-centered conversation about why their risk factors put them at increased risk for both getting the RSV vaccine and the complications or the RSV disease and the complications associated with it. And then, making sure to answer all of their questions if they have questions about the safety or about the RSV disease itself, just being really open with that conversation. Does anybody else have anything to add?
Yeah, I think right. I totally agree, and just highlighting the fact that this is you're someone that you have a risk of having hospitalization due to RSV over the next year or two, and we can give a vaccine that can help decrease that risk quite effectively. Is it's a lot of the kind of the argument or the giving someone a good reason to avoid complications down the line.
I think also gauging their knowledge about the vaccine and what specific questions they have will tailor the education and the discussion. Allie, was there anything you wanted to add or?
No, I echo all of the things. And from a pharmacy perspective, a lot of these vaccines are given in pharmacies. And I think it's important to make sure our pharmacy colleagues are educated. If you send in a prescription for an RSV vaccine for a patient, or if you're in a state where, like in Arkansas, I have prescriptive authority, starting the conversation in the clinic with the patient and asking them, say, hey, if you have more questions, ask your pharmacist, and have that collaboration with your pharmacy team around you. Know who those people are and just develop those relationships. And I think everyone having the same message really speaks to the patient. So that's my 2 cents.
Thank you, everyone. We'll move on to the next case. Okay. This is a 62-year-old female who didn't get the RSV vaccine when the recommendation was for those over the age of 60 and now wants it, doesn't have any risk factors, and is coming to you from her yoga class. Would you still vaccinate this patient, or how would you advise the patient who no longer qualifies for the vaccine? Because we know the recommendations have changed quite a bit over the past couple of years.
Yeah, I think this is a little bit less straightforward because it feels counterintuitive to recommend against vaccinating patients. I would have once again an open, honest conversation and let them know that the guidelines have changed and that they no longer, because they don't have risk factors, fall within the recommended criteria, and that might result in insurance not covering the vaccine. I think that's the biggest risk here. As far as the safety profile, we talked about the FDA approval for these vaccines, so I would be comfortable with her receiving the vaccine. It's just that it might incur an out-of-pocket cost for her. So I think that would be the biggest concern that I would raise for her.
Any other comments? I think this one's, like you said, a little more straightforward, and it would be a shared decision-making approach for this. Discussing risks and benefits and whatnot. I don't think there are any additional comments, so we will move on to case 3.
Actually, I do have an on that one. So I think I would really emphasize in this situation how evidence evolves. And we always want to make recommendations for the benefit of the patient, right? So I think this is also a good opportunity to share with the patient that science changes and evidence changes, and that changes our recommendation. So I think this is a good time to point out to the patient, hey, we follow the science. So just another point there.
Thank you for that tidbit.
And also, just really briefly to point out, like, how confusing this is, right? Both for patients as well as provide. The fact that this is the second change, right, in really 2 years to these guidelines. How it's so challenging to keep up with all of these recommendations. So, if you're out there like scratching your head and like, oh, I thought it was this, and it's been changed again, we're there with you. But Allie's right that, it really is based in the science. We really have to follow those studies, and that's why the guidelines change. And so really encouraging, our patients to do the same.
Before I move on, is there anything else from this question? Sorry. No, that is okay. Thank you for that discussion. All right, we'll move on then to the third case. This is a 78-year-old male who's interested in getting the vaccine, but he has a lot of questions about the vaccine, and your clinic is already 30 minutes behind. Given that you are in a rush, what would be your approach to having a patient-centered conversation that is also efficient in this case?
So I'm going to let Joe go because I have a lot to say on this. So go ahead.
You'll probably say some of the same things, but as I say, I mean, part of it is, is given the opportunity to, continue the conversation, even if you can't squeeze everything in over the next like 15 minutes or even couple minutes, given the opportunity to continue the conversation and maybe give that prescription so that he can continue that conversation with the pharmacist or with Allie or one of her colleagues to, really understand more. But go ahead, Amy.
Yeah, so I agree with that. So most of the time in a primary care clinic setting, these conversations are coming up during annual physicals, male, women exams. And it can feel rushed. We have like 15, 20 minutes to cover all of their health and maintenance and all of their chronic issues and all of the vaccines. So it can be challenging for sure. But really taking the time to find out what his questions are and really doing the best you can to answer those questions and concerns to the best of your ability. As I mentioned, handouts can be really helpful for this. So either electronic or paper handouts. A lot of times I'll just put ones straight into their portal so it'll be there if they want to look at it later. And this is a situation where it actually really is in our benefit as clinicians that these are prescribed vaccines, right? So I can have this conversation with the patient, and if they're amenable, I can go ahead and send that prescription to the pharmacy and encourage them to have that conversation with the pharmacist, as Ellie pointed out. Don't feel like we have to answer all of the questions and really do all of the heavy lifting around these conversations by ourselves. If the patient changes their mind later and decides not to get the vaccine, it just hangs out in the prescriptions. The pharmacies probably don't love that, but it's better that it's available to them should they decide to get it later. So a lot of times I'll ask them if it's okay for me to go ahead and send these vaccines. And one thing in our clinic that we found really helpful is there's a way you can set up the electronic orders so that it can cover multiple brands. So it can be tricky to figure out which ones are covered by their insurance. I feel like that's improved a little bit, but if you have kind of a blanket prescription for multiple brands of these vaccines and send that, then that kind of leaves it up to the pharmacy and the patient when they're getting the vaccine to see which one is covered for them. So, but the other big thing is don't pressure him if he's not ready. So offer to send in the prescription, but don't sort of put the pressure on him or, make him feel guilty if he's not ready to get the vaccine. Sorry, that was a lot of information, but I have a lot of thoughts on that.
No, thank you for the feedback. And I think also giving the patient the opportunity to come back for a brief visit, keeping that door open for further discussion is an option, and that might help increase the vaccine uptake. Ellie, did you want to add anything to that or?
Yeah, I love the collaborative approach. And I think the communication on this is key. If we're sending in a prescription and then we don't really know what happens with it, or we don't have that strong recommendation that goes with it, I would recommend to try to send a note with the prescription that says, hey, this patient has some questions. can you take the time to answer these? Or, just some kind of note on the script, like in the comments or however you can send it electronically, that does say, kind of gives the pharmacy a heads up. So even the pharmacist may be able to research the questions ahead of time and be able to have some great information right there at the fingertips for that patient. I will say this weekend, unrelated to RSV, I did receive a question from a mom who said that she was concerned that her pediatrician was Googling or researching her questions right in front of her. And I kind of reassured her, I'm like, this is a time that we haven't really been in before. And a lot of us don't have, like in pharmacy school, in medical school, in nursing, in any of our professions, when we were taught immunizations, we're really taught that our patients are going to trust our recommendations, right? So we missed the boat there and we're in a different time. So I do think it's important to start having these conversations with our patients that if I don't know the answer, I want to look this up and get back with you because I want to provide the most accurate answer for you. And I want you to feel confident and informed in your decision. And I can get that information. It just might take me some time. So please let me get back with you. We use that in pharmacy all the time. I don't know the answer right now. Please let me look this up and get back with you. And I think that is certainly a trust building approach too, to not just make something up, but to really take the time to find the answers to those questions.
Thank you. Next case is going to be our last. 47-year-old female on biologic medication for her Crohn's is wondering if she should get vaccinated for RSV. She's a pediatric nurse at a local children's hospital. How would you counsel this patient about the risk and benefits of getting the vaccine or not? Kind of similar to the other patient who didn't qualify for the vaccine. Any takers for this one? Joe, I think.
Yeah, I can start. I mean, I'll say it is similar, and it's definitely a shared decision making with this patient, and listening to her concerns about which probably are around her potential exposure to RSV frequently at a pretty high risk environment, and really talking through that with her, but then also like bringing up the concern that her insurance may not cover the vaccine, and this could be an out-of-pocket expense, but potentially maybe one that she's willing to do. I think it also brings up something that occurred to me as we're thinking through all these discussions with patients. Is another thing to bring up with them is what is their contact with young children, whether it's grandkids, schools, etc., and how that may impact their decisions about whether to get vaccinated or not vaccinated. Can kind of push them help nudge them one way or another, based on how much exposure they have as little kids that may be carrying RSV, left and right.
Anyone else?
Yeah, I agree with Joe. So the exposure is definitely an important piece of it. And then in this patient, because she is on an immunosuppressant medication, that also increases her risk. So I think with this patient, more so than the previous one, I would support, if she wanted to get the vaccine, I would still make sure that she understood it was outside of the recommendations and might cost her out of pocket, as Joe mentioned. But I think I would be less hesitant to encourage the vaccine in this patient because the benefit really seems to outweigh the risk.
Allie, not sure if you wanted to add additional information to that.
Yeah. So again, I think just this team approach of trying to, insurance coverage. There's actually a question in the chat that says, who is covered from insurance and how is it not covered from insurance? Please explain. So I think this is actually a perfect time to talk about that. So insurance coverage, of course, varies by insurance, but as of as of now, the Affordable Care Act makes it to where insurances have to cover ACIP recommended vaccines. So if the ACIP and CDC recommend the vaccine and there is an official recommendation from CDC, then it has to be covered by insurance. Now, insurance companies have 1 year from the time that that recommendation is placed from the ACIP to actually include that in the coverage. But just because FDA says that that it's approved does not mean that insurance covers it, because the insurance coverage is really tied to the ACIP CDC recommendation and not the package insert or what the FDA says. So I hope that is a helpful explanation of that. Does anybody else want to throw something else in there about that specifically?
I was just going to say it can be really confusing for patients and once again for providers to figure all of this stuff out. So I just encourage my patients to contact their insurance to find out if it's going to be covered or not. I don't know at the pharmacy side if you guys have that information readily available, but I feel like in clinic we don't oftentimes. Yeah, so just have the patients contact their insurance and find out if it's going to be covered or how much they're going to have to pay out of pocket.
So a lot of times in pharmacy, just as an explanation for what happens, is if we get a script, or again, in Arkansas, I have prescriptive authority as a pharmacist, so I can prescribe these myself. Really what I'll do is I'll just start running claims. I'll see what I have in stock and I'll see what's covered by insurance. And really it's trial and error with claims. But that's really what it takes a lot of times. It's really frustrating to call insurance companies, but to be truthful, for the pharmacist or the pharmacy to call the insurance company might be helpful for the patient to choose to vaccinate because they don't have to deal with the insurance company. We do that. We really do a lot. So, we all of us really do a lot. But as far as the coverage, yes, we can be very helpful for that. Of course, state Medicaid plans are a totally different animal in this population. Medicare, again, they're covered by what the ACIP or CDC recommendations say. And that's typically right now, RSV vaccines are covered through the Part D plan. And that there are patients who don't have Part D, or if they have a Advantage plan, then they may be different. So I would say if they're administering in the pharmacy, if you're recommending them go to the pharmacy, give it to the pharmacy and let them help the patient.
Okay, that's a good transition to the Q&A session, and I will hand it over to Joe. Thank you, everyone.
Thanks. And if anyone, again, see on the screen there, go ahead and hit the Q&A button at the bottom if you have any other questions you'd like to go over. And I think we've covered a lot. One person just asked some additional advice on how to counsel patients for, I think, related to some of these pharmacy decisions. I think one thing I would bring up, and correct me if I'm wrong, Allie, but I think the out-of-pocket uninsured price for some of these vaccines is hovering around $300, in most states.
So for some patients like that third patient, it may be worth paying $300 out of pocket if they have the ability to do that. That peace of mind might be worth it for her. So once again, it's going to be very patient individualized as to whether or not it's a good idea to get it or not. But once again, sometimes we don't have to make that decision. We can just send the script and then let the patient and the pharmacist and their insurance figure it out.
Yeah, I do agree. And I think again, the communication with the pharmacy team, and if you have that relationship with the pharmacy, let them know that what you're doing. I always I do a lot of education with pharmacists too here in Arkansas, especially. But that communication is key, right? So if I get a prescription from a physician and I'm like, oh, this patient doesn't qualify for this vaccine, and then they come into the pharmacy and I have to be the one that explains, sorry, your insurance doesn't cover this. That puts all of us in that's negative on everybody, right? The patient might not be trustworthy of the system, right, in the future, and we don't want to do that. So the more transparent and honest we can be about all of these things, saying, letting them know ahead of time, or even writing it on the script that you have talked to the patient that it might not be covered, but a lot of times I'll when I educate the pharmacist here, I'll say, or in any profession, I ask them, if you send a script and this patient doesn't qualify, let us know the reason, put it on the script, the reason why you want them to get the vaccine. So that helps us to be able to have that conversation with the patient without calling your office and trying to figure out, okay, what in the world happened? What was the conversation that you had, because the patient doesn't remember. So just that interprofessional collaboration, really, that I think we call it the immunization neighborhood, really all working together to send the same message, to say the same things, and work together. There are some things where we stay in our lane, right? Like, but I'm not going to draw labs for patients, or different things, but dealing with insurance with the prescriptions, yes, it's going to be me. So if you're putting it in my lane, give me some advice, give me some info on whatever you have already done, and that helps us in the pharmacy world.
I think that's really helpful to know, because sometimes I put the comments in that comment to the pharmacy section and don't know if anybody actually reads that. So that's really good to know that those are helpful. And especially for patients like this, like you said, where it's kind of in that gray area, and just that communication. I think as much sort of interaction with our pharmacists as we can have, the better. So doing education with clinicians around these issues, I'll get like pages from the pharmacist sort of like clarifying, like, my prescriptions and, conversations that we've had with the patient. So I think just the more open communication there can be between the pharmacists and the clinicians, the better.
Yeah. All right, I'm going to switch over to one other question here. Questioning, are these vaccines updated often? Because the person feels that these frequent updates could actually discourage patients, or like Allie mentioned earlier, like create this distrust in the medical community and our scientific advice. Any comments on this issue of updating recommendations and encouraging trust in our patients?
Oh yeah. Sorry, I feel like I've spoken a lot, but yes, I think the more transparent we are with our patients about how the recommendations are made, and really that, these vaccines are studied so extensively, so extensively. They go through, years and years and years of studies, trials, and once they're recommended, like, they go through the FDA first, and then they go through CDC, and then, like, just kind of maybe understanding and explaining the process of vaccine approval, and making sure, trying to educate our patients on that level of saying, okay, yes, the reason that these recommendations may change is because science changes. We learn things. While that can be frustrating for everyone, the reality is these vaccines are monitored after they're on the market. So once we monitor for safety, and we're monitoring these things in a massive population, and we are monitoring for safety, and we're monitoring how long they work, and different things. So absolutely, later on, there may be changes, but we have to go with what we know. What we absolutely know, what we know at that point in time, and we can make changes later on. Unfortunately, with RSV, yes, there have been a lot of changes. This has been definitely a struggle, but they're so great. Like, the vaccines are really safe and very effective, and very helpful. So while these challenges can be frustrating, I think we have to really stay positive when we speak to our patients, and explain the process a little bit, make sure we understand the process enough to explain it to our patients in their terms.
I think it's also important. We notice the evolving science with the new vaccines, right? The ones that are already established, I think we know the efficacy and safety. So it's really the newer ones because of, as you mentioned, the evolving data and safety and efficacy and all that. So it's important to highlight that.
So I think we'll have to tie things up here. We're coming to the end of the hour. I want to thank all our panelists again. Thank you for being part of this. Thank you for the AHA for sponsoring this great program, and encourage everyone to stay tuned. This will be posted later on to the AHA website for future viewing. And thank you, everyone.